Just a day later, I am thrust back into the disarray of an oncology ward. A glossy blue brochure finds its way into my hand. The marketing literature reassures us on the oncology department's state of the art radiation therapy equipment. The schedule of treatment has been organized around the CyberKnife. For those medically untrained, a discursive regime of medical precision sculpts CyberKnife's power. The system is characterized by its sub-millimeter accuracy. It can deliver high energy photons from hundreds of beam angles. The measured movement of its robotic arm is claimed to give the oncologist the confidence to bombard the tumor with doses of radiation that would otherwise risk healthy tissues. It features a 6-axis robotic manipulator for precision, a robotic couch for containing the unpredictability of the human body, and a linear accelerator for radiation delivery. Hi, welcome to the MedTalk series by the AIDEM. Today I'm speaking to Dr. Debnarayan Dutta. Dr. Dutta is the professor and head of the Radiation Oncology Department at Amrita Institute of Medical Sciences. CyberKnife is a new kind of radiosurgery system that is available only in a very few hospitals in the country. But Amrita has it, and Dr. Dutta is in charge of the CyberKnife system here. And I was one of the fortunate patients who was able to avail this CyberKnife treatment. And I think I had a review scan just a month ago, and the lesions in my brain have reduced considerably. So, as a patient, I feel very compelled to spread awareness about the CyberKnife. So, we have Dr. Dutta to speak to us about the CyberKnife system. Doctor, could you tell us a bit about your journey as an oncologist?
Yeah, see, I am from a small city in West Bengal. It is called Bardhaman, and I have done my graduations and post graduation from Calcutta University, West Bengal, and then I came to Tata Memorial, Bombay, and did a fellowship in radiosurgery there. That time, Brain Lab system was there, which was the standard radiosurgery system, and I got training there. I was in Bombay for 4 years. Then I joined Apollo Hospital, Chennai, when the CyberKnife came in 2010. So 2010 to 2016, I was there, and I was taking care of the CyberKnife there. And from 2017 onwards, I am here in Amrita Institute because they got the CyberKnife in 2017, and it is an academic center, and we can work in a prospective setting. We can work in a setting where the outcomes can be measured, and has its own advantage of being in academic center. That is why I am here.
Doctor, you were saying that there are very few CyberKnife machines in India.
Yeah.
Do you know how many are available in India?
Now I think 7 are available, but I think 6 is functional now.
Okay. And if someone is considering radiotherapy, the oncologist has told them that they need radiation. What are the sort of questions that a patient should ask there?
See, uh, radiation is a treatment, and CyberKnife is one type of radiation delivery machine. So it depends on some radiation oncologist to decide that whether we need CyberKnife or normal kind of radiations. Usually, if we are treating only the tumor, not too much of normal tissue, then CyberKnife is really good because we can deliver with high dose and very precise. Side effects are minimal, and normal tissue does not get that dose. But many times we need to treat microscopic disease, means the tumor cell is within the normal tissue. So we have to treat a large area of normal tissue to eradicate those microscopic cells. There, the high dose radiation is not going to be useful because then you are going to damage a lot of normal tissues in that process. In that case, we don't do CyberKnife kind of treatment, we do normal radiation kind of treatment.
The night before the encounter, I am rolled into an MRI machine that would generate thin slice images of my brain. To exorcise the malignancy, the machine needs to see my body in its own terms. A radiograph of my brain is digitally constructed from various angles and transferred into the CyberKnife software. This would be combined with other image guidance systems installed in the facility, allowing the software's tracking algorithms to track my skull and spine in real time. In the morning, I am wheeled through a central atrium, past a series of doors with bright cautionary stickers. The signs on the doors are mostly directed at women who are or may be pregnant. Those suspected of carrying life are strictly required to keep away from these doors. In these warnings, you encounter a familiar metaphor. Cancer is the opposite of life. The CyberKnife is part of a vast arsenal of medical technology that is designed to identify and eliminate malignant cells that have invaded the perimeter of the body. The allegories of the war room are bound to find their way.
This is a dedicated radiosurgery machine, and it can do wonder because we can treat in such a short time and very precisely without any side effects. So many indications are there now there for CyberKnife machine.
Yeah. So, what are the advantages of the CyberKnife as compared to older machines? Because
See,
radiation therapy has
yeah.
existed for a long time now,
Yeah,
right?
now radiation therapy is there for almost 100 years,
Okay.
and if you see that the radiation is one of the top five uh, the inventions that has happened in human history in last century. So, but when you talk about radiosurgery or cyberknife kind, the toxicities has come down and treatment delivery is more precise and the treatment time has reduced significantly. So now it is not about 30 days or 35 days of treatment, it is only 5 days of treatment. So it becomes so easy for the patients to take that. And if you don't see any skin reactions, mucosal reactions, and patient can tolerate the treatment
Right.
well, it becomes more acceptable to the patients. If you are able to deliver high dose, what we do with CyberKnife, we can have a better control. So that has happened over the years. Like in prostate tumor, with CyberKnife, we can treat in 5 days, and the outcome is as good as any surgery or standard radiations. Side effects are less than 1%. Patient is having grade 3 or more toxicity, and outcome is excellent. Outcome is 10 years survival is around 90%. So you can't improve on that and treat in 5 days time without any acute toxicities, and long-term toxicities are very less. So that is what as the CyberKnife has done.
Can you use the CyberKnife for any kind of cancer, or are there specific sites in
No,
which?
CyberKnife is not for all cancers. CyberKnife is mostly made for smaller tumors, like when it is a very small tumors in the brain, lung, prostate, liver, or metastasis site. We do CyberKnife treatment, and that gives excellent result because we can deliver very high dose in those situations. But in larger field like whole head and neck tumors or craniospinal radiations or breast cancer tumors, where we treat a large amount of normal tissue, there CyberKnife or such a high dose radiations is not recommended.
Dr. Dutta, could you tell us a bit about which organs, what are the indications for CyberKnife?
See, the indication for CyberKnife is expanding and expanding very rapidly with the informations, with the data coming out, with the outcome data. Now, for brain, for benign brain tumors like meningiomas, acoustic schwannoma, AVM, CyberKnife is one of the standard of care. For trigeminal neuralgia, CyberKnife is used to reduce the pain, and that is been used for last 40 50 years with gamma knife and now with CyberKnife. Now for brain metastasis, now radiosurgery is become a standard of care. Now the whole brain radiation is gone, means we don't want to treat with whole brain radiation because it has lot of side effects. So radiosurgery is now becoming the standard of care. For lung cancer, early lung cancers, radiosurgery has shown that it is the effectiveness is same as surgery with minimal side effects. Prostate cancer, localized prostate cancer, radiosurgery is considered to be 5 days treatment, as good as 35 days of radiations. So now people are going in for a shorter course of radiations in a localized prostate cancers. Some metastasis like spine metastasis, it has shown that if you treat with radiosurgery in a shorter course, then the pain management is much better compared to the normal kind of radiations what we use. There are so many other new indications that are happening with CyberKnife, like atrial fibrillations or some kind of neurological disorders like mood disorders. Ablative radiosurgery with CyberKnife is becoming a standard of care, but still these are on the process of getting standardized. But brain metastases, primary brain tumors, benign brain tumors, lung cancer, prostate cancer, liver cancers, CyberKnife is considered as the standard of care now.
So when I was diagnosed, I got a barrage of words. I heard chemotherapy, I heard surgery, I heard radiation therapy. So do these all work in combination or are they
You
different?
see, when someone is diagnosed with cancer, so we try to eradicate as best as possible. Now, if we add chemotherapy, surgery, and radiation, the side effects are minimal for all
Okay.
those, and we can get the benefit of all these treatment facilities. Chemotherapy works mostly for microscopic disease. Surgery works for disease which can be easily accessible or surgery is possible. Radiation therapy is mostly for microscopic disease which is left behind after surgery or surgery is not possible. So all these are combinations, each treatment which is now used for most of our cancer patients, and that is how we try to cure cancer as best as possible.
And when we talk about the CyberKnife, many patients might be worried about side effects. So people usually
Yeah.
ask about, can I be around my family and my children after the treatment? Will I be emitting radiation? Are those concerns that?
No, see, no one is going back with radiation at home.
Okay.
So that is not at all a concern. So most of the time we ask, I face this often. Patient asks, can I talk and be with my children when someone is getting radiations? I think they should be with their families more often, because that is the time when someone is getting treated. They are emotionally more viable. So they need some kind of emotional support. So they should be the families, and there is no risk.
There's no
You can share food, you can stay with them. No one is taking radiation back home. So these are myths that need to be broken very much, and need to be broken appropriately.
So in my case, I was diagnosed with cancer in April, and it was a lung cancer with metastasis in the brain. So in my case, only the metastasis were treated using
Treated
the
with CyberKnife.
CyberKnife. Was it possibly because the lung tumors were too large to be treated by?
No, see now what actually is done for someone who's having lung primary with the brain metastasis, and mutations are there, ALK mutations or EGFR mutations, ROS mutations. So we have targeted therapy for that, which does not work in the brain.
Okay.
So we treat the brain with our CyberKnife to have a good control, give systemic therapy to take care of the lung. It is not only the lung lesions, if it is there in the liver or microscopic disease in bone or somewhere else, it is taken care of. And if after a certain period, means 4 months or 6 months of period of systemic therapy, if residual disease is there, we are going to target that with our CyberKnife. So it is going to happen, it may be required for treating the primary disease as well. When after the initial systemic therapy, there is a small residual disease left behind in that place. And that is the standard of care, to not to treat the primary lung early if there is a targetable mutations we have, because that does not take care, the systemic therapy does not take care only the disease which is seen, microscopic disease also is taken care of with that.
Take us through a typical day
Day.
in the life of a CyberKnife.
CyberKnife.
What is a session like?
See, the patient comes for the treatment. The most important is to have a consultation, understand what is the disease, and understand what is the expectations with the CyberKnife treatment. That is critical, because see, someone who is having a primary lesion in the lung or primary lesion in the brain, benign tumor, we are expecting a long-term outcome, that the toxicities are critical. Sometimes when there is a metastatic disease, we are expecting shrink. Or radiologically, there should be response. So the outcome, the expectations are different, and that has to be explained to the patients. When you are doing a long-term outcome like meningiomas or acoustic schwannomas, so benign disease, we give lower dose
Okay.
to ensure that toxicities are not there, long-term toxicities are not there. When we see a high-grade tumors or metastatic disease, we give a high dose to see the response, and we have a long-term control in that with high dose, which is required. So how we approach a patient is little different based on the primary disease and expectations, age of the patients and volume of the disease. All these things makes a lot of difference. Once you do that and see that what is our treatment plan, we do MRI or PET scan and CT scan, then do a computer program. That computer program comes into our machine, and this machine actually do the delivery of whatever we have planned, and that takes long time for doing a planning and things than the delivery. So we do see the delivery, but it's a 50% of our time goes on planning and ensuring that we do a appropriate plan for the patient. Now, in terms of delivery, we ask the patient to come and lie down here. We have a tracking system here which helps us to track the respiratory motion. There is a dual tracking system in CyberKnife, one with the fiducial where the internal motions are taken care of. This one is external motion, the breathing motion is taken care of. So both the motion taking care makes our treatment delivery more accurate, which many of the machines do not have. But CyberKnife is unique in that sense that it has a tracking system which is much more advanced than many of the machines what we have now.
When you say fiducial, you mean there is a gold
Gold
seed
seed
that is
is-
inserted
yes,
into the
it's-
body, which is tracked by the machine.
Yes, yes. So gold seed has its specific density that our body no structure have, and a machine is fed with a density. We call it Hounsfield unit. So based on that Hounsfield unit, we actually can track the gold seed, very small gold seed inside it, in the prostate, in the liver, sometimes in the lung. We put gold seeds to track these lesions, which are deep-seated one. For brain, we don't need it because the skull itself is a structure, which is a fixed structure that can work as a fiducial for the skull brain lesions. Now, in terms of delivery, this is a robot. It is an industrial robot. The same robot is used for making a car, manufacturing industry. They use the same robot for Japan, and there is a linear accelerator. There is a compact linear accelerator, which is used for generating the
So
radiation.
this bit is the linear accelerator.
Linear accelerator, yeah.
Okay.
And this is the robot.
Zero.
This is an industrial robot.
Okay.
It has 6 levers, and 6 levers have unique property that either it is yes or no, 0 or 1 means it does not get stuck in between, either here or there. So that is the kind of lever which is used here. So the errors are not there. Many times what happens when there is a machine and there is a mechanical error is there, means machine can get stuck in between or little angulation error can happen. But as this only lever is there, which has a 0 or 1, means either it will get stuck here or stuck there. So chance of error, mechanical errors are minimal with a CyberKnife, and this is a unique thing that has been designed using this robot. There are some cones, small cones,
Right.
which actually allow us to see that that we can make the beam as our requirement. So if it is a very small cone, small beam can be passed on. Is a larger cones, depend on the tumor size.
Okay.
We choose the cones here. There are from 5 millimeter to 6 centimeter cones are there, and we choose those cones based on the requirements.
Okay.
And for one patient, actually not only one cone is required, 2-3 cones are required. So based on how many cones we require and how we amalgamate all the informations from different cones delivery, so that we can have a more uniform dose distributions and spare the normal structures as much as possible. This is a X-ray detectors. These are the X-ray generators
Mounted on the roof.
mounted on the roof, so that from there, and it is a 90-degree apart. So if you see any X-rays, you take 90-degree apart, we can have a 6D motion corrections. So this is a unique thing. If you have a two parallel, the Z axis is not taken care of. But if you do two in a 90-degree angle with each other, then the rotational motion is also taken care of. So that is how these X-rays work to see the patient is positioned in appropriate position or not, and the patient is moving during the treatment or not. So it is a real time. So they take X-ray on a regular basis during treatment every seconds, match the patient how the patient is positioned during the treatment, and the treatment is delivered accordingly.
Doctor, can you tell us a bit about how it looks like after the treatment? What kind of after treatment care should a patient take?
See, when we're doing it radiosurgery with such a high dose radiations, in different areas have different kind of issues we need to take into account and need to follow that. Like in brain, when it is a closed structure, so if you give a high dose radiation, sometimes there is little edema, there can be headache, there can be deficits that can happen. So that need to be taken into account. We usually give steroids for a short period of time after the radiation, um, high dose radiation, so that this mitigates. It can reduce the headache and the edema component. Still, patients have 5% of the patients do have this edema. When you're giving such a high dose radiation, sometimes we call it radiation necrosis. That can happen. But 90% of the radiation necrosis is asymptomatic. The patient don't have that symptoms. But radiologically, there can be, you can see there's a necrosis is there. So with high dose radiation, all these problems are there. But if you consider the benefit with such a high dose radiations and the and the complication rates like headache, some kind of deficits or radiation necrosis, is much better than the
But
normal
what
kind
does
of
deficit
radiations.
mean in this context?
Deficit means sometimes what happens if a lesion is there in a very eloquent area, very critical area. So if you give such a high dose, there will be little edema can happen, and that edema can have a pressure effect on the adjacent structures. Like if it is close to the motor cortex or brainstem, there can be pressure effect and can have some deficit can happen.
Okay.
Someone can have a memory issues, can have a speech issue, someone can have a motor deficit.
Okay.
These are all transient for a short period, but it can happen
Okay.
after this high dose radiations, and that need to be taken into account. We see now we are doing this 7A for last 15 years, and what has happened over the period of time, there's a learning curve.
Right.
And the moment you understand and can predict that these patients will have little issues in treating with CyberKnife, we don't treat them, or we treat in a taking care of the issues which we are expecting. So with the learning curve, the complication rates come down significantly. More important is to have our own data. So unless until we have our own outcome data from Indian patient populations and see that high dose radiation, shorter course of radiations, is it more cost effective for the patients and it is more effective in terms of outcome. So the acceptance is not going to improve.
Correct.
Now we have our own outcome data, and few centers are slowly having the centers which are producing their own work, and the acceptance is improving significantly with CyberKnife.
And what kind of data have you collected? What does it show?
See, we have treated around 3,500 odd patients now, and as I told, all patients are in some kind of protocol setting. So, like in brain metastasis, we have our data of 411 patients data we have already published, and in a prospective setting, there is a randomized study going on with memantine with reduced surgery, which is first time in the world we are
Okay.
doing a randomized study, and that has also been published recently, which has shown that in radiosurgery with memantine, they can significantly preserve the cognitive functions. So that is something which unique information that has gone. We have in India or most of the developing countries in brain metastasis, usually we used to treat whole brain radiations, and radiosurgery only treating the lesion was not the common indications. But after our study, many of the centers have started stopping whole brain radiations and doing only radiosurgery, which is a standard of care in Western population. So there's a contrast different in metastatic disease treated in Eastern Western countries and in developing countries. Now slowly trying to match it and trying to make a similar kind of treatment approach based on the data what we have. For liver metastasis, we have our own work. Hepatocellular carcinoma with portal vein thrombosis, which is something new and very common in Kerala. And many of these patients with a hepatocellular carcinoma, they present in little advanced stage here
Okay.
in India and especially in Kerala. And they have a portal vein block. And once the portal vein block is happening, the patient's liver get decompensated very early. So if you are able to open the portal vein block, then the chance of having a long-term control or delay the decompensation is much better. So we have our own work, and with that work now, it has come into the protocol to treat portal vein thrombosis with reduced surgery. we have started in 2017, and now it has been accepted as the standard of care for prevention, and many of the centers started using that. For kidney tumors, radiosurgery was considered as a standard of care for patients who have surgery is not possible, but there's not much data. Now we have a prospective data with us which have shown that those patients where the surgery is difficult, or patients have a kidney tumors in both the kidneys, and one kidney is removed for some reason, and another kidney there is a disease and we cannot remove it. If you do radiosurgery, we can actually preserve the kidney function as well. So this is a significant data we have. We are doing an APBI, we call it for breast cancer, small lesions in the breast. We can do APBI, means partial breast irradiation with our CyberKnife, and we have a interesting data on that to treat that with lesions. So for meningiomas, for acoustic schwannomas, for AVMs, we have our own prospective data, and I think that is going to change the way we look at radiosurgery or CyberKnife in India, and things are getting accepted more often.
Thanks so much for speaking to us, Doctor. It was very valuable information. This is the kind of information I did not have when I became a patient. I went to a hospital and they told me to get radiation, but not what kind of radiation options are available.
Yeah.
So I think it is important that this kind of awareness is spread among the general public, especially because so many cancer cases are increasing. So thanks so much for spending time with us, telling us all about your work. Thank you.
Thank you.